Hi, I'm Dr. Chuck Murphy at the Inova Heart Recovery Symposium, and I'm joined by Dr. Tony Perez from the Cleveland Clinic. Dr. Perez, welcome.
Thank you for having me. I've had a great time at the meeting.
Great. I'd like to talk about the decision making for the mechanical circulatory support. So if you could talk about your decision making process.
Sure. I think at the center of the decision-making process for any patient who comes in with cardiogenic shock, whether you're going to pursue a medical therapy strategy or mechanical circulatory support, is having invasive hemodynamics. And there's a lot of very important information that we get from invasive hemodynamics that really allow us to make decisions in an appropriate period of time when we're dealing with patients who have very, very high mortality. I believe that it's impossible to appropriately treat cardiogenic shock without invasive hemodynamics. And invasive hemodynamics that are not just measured at one time point in the cath lab, but over time continuously in the context of an ICU. The most important piece of information that we get is the filling pressures, obviously, what I think everyone historically is comfortable with. This allows us to understand how much a ventricle is struggling if a wedge pressure is very high. We also get information about cardiac output, and in context of reduced cardiac output or a cardiac power, if we also incorporate a map, that's really what's going to drive the decision about the initial strategy for cardiogenic shock. And in some patients, the right answer for that is medical therapy, in a trial of medical therapy with vasodilator therapy with sodium nitroprusside or an inotrope. But in some patients who are in profound shock, who are requiring a lot of vasopressors, it's very clear that a mechanical approach is what's indicated. And the right heart cath gives you a sense of whether or not your mechanical intervention is having an impact. So for example, if a patient is in a cath lab or in an ICU setting with cardiogenic shock from either ischemic or non-ischemic heart failure, starting with a balloon pump is a reasonable strategy. But in short order, you have to use the right heart cath to understand whether or not that balloon pump is successful. And if in the next half hour or hour or so, you're seeing there isn't an improvement in the cardiac output, there's where I think thinking long and hard about going to the next step for either a transaortic, a mechanical circulatory system, or ECMO is appropriate.
So let's talk about some of your patients, the patient with chronic heart failure that you're following, and then they come in with an acute decompensation, right, and they're in cardiogenic shock. What are you aiming towards in terms of where you hope to get that patient?
Yeah, I think one of the things my specialty, advanced heart failure transplant cardiology, really focuses on is not only the acute management of patients in an ICU setting, but what the long-term strategy for that patient is. And obviously, all of us believe that if someone can keep the heart they were born with, without a permanent machine, that's the best option, right? And in our acute myocarditis patients are great examples of patients who can, or ischemic patients who are revascularized, who can really return back to life with the native heart. But there is a subset of patients for whom their heart is already too sick. And we know that further revascularization or further attempts at optimizing medical therapy are going to fail. And that's really where my specialty can come in and identify who that patient is. And then the strategy changes from, let's leave him in the ICU with some medical therapy or to attempt to restore cardiac output, or a temporary mechanical circulatory device, and transition the focus to figuring out whether this person is a candidate for a left ventricular assist device or cardiac transplantation.
And of course, it's so critically important to avoid end organ dysfunction, right? Because if you get renal failure, then that can really close some doors.
Absolutely. I think the key thing with all of these patients is they have to be assessed early. And if even a few hours of time is enough to cause some end organ injury that will decrease their ability to survive whatever intervention you provide them significantly. So that's the importance of the right heart catheterization, of stabilization of the patient with medical therapy or a mechanical circulatory support device. And then a quick a decision that doesn't have to be done in a half-hour setting, but can be done over a day or two to figure out what the long-term strategy for the patient is going to be, whether LVAD or transplantation.
And I guess another arena that pops into my mind related to your specialty is the patients that have a durable LVAD put in And then because oftentimes they do have some degree of right heart dysfunction, one has to support the right ventricle.
Yeah, I think one of the most challenging things we face in cardiogenic shock is thinking about the right ventricle, because there's not one strategy that we use to assess RV function that actually has great sensitivity or specificity for how the RV is functioning, neither imaging or even invasive hemodynamics. So it really is a combination of approaches. But in those patients, the right heart cath, I think, gives us the best information that we have, given that it is limited in the acute setting. And when you use an index such as a PAPI index or the PA pulsatility index that incorporates the PA systolic, PA diastolic, and the CVP, that gives you a sense of how bad an RV function is in that setting. When someone is going into an LVAD, if we feel that their PA pulsatility index is very poor, that may, for example, cause us to say, well, we're going to have a low threshold to support that RV with some RV mechanical support, whether that be an RP Impella or other options that exist in that setting, or to even forego the LVAD altogether and really pursue transplantation in that context. So that decision of RV function is absolutely critical, especially in patients with cardiogenic shock, because that's going to drive your decision about whether you're going to pursue an LVAD or if you're going to be in an ICU for a period of time waiting for a heart. And if you're going to be in an ICU for a period of time, you have to figure out what your acute mechanical circulatory support option is going to be. And those questions are quite challenging.
But you know, it's really an exciting time to be in your field, because you really do have the opportunity to give good quality of life to many patients that really in the past we couldn't do.
There's nothing more rewarding for us than to have a patient who comes into our ICU near death, and that we could 2 or 3 months later see them in clinic walking around with their family and talking about their children or their grandchildren. This happens, right? This is why we do what we do. So even though these decisions are complicated, the care of these patients is expensive, it requires a tremendous amount of expertise of many specialties, both on the physician, nursing, ICU team. This care is very much worth it, and it saves many lives.
Well, I think we all recognize what a preeminent organization the Cleveland Clinic is, and what great care you do deliver to your patients. So we very much appreciate you being here.
Oh, thank you for the compliment. It's really an honor.